The topic of my presentation is the pillars of the nose. I'm Assistant Professor Gabriela Kopacheva. I'm coming from the University Skopje, North Macedonia. And why I choose this theme, first, I would like to say thank you to all these men and one woman, Professor Witzke Fokens, Valentin Tomajic, Georg Galas, Mark Scheithauer, and Jem Mecho, who support everything to start the first Rhino Forum, which was held in Skopje, and now the second and third, it will be in Athens in Greece. First, before I start my presentation, I would like to say about my review about the pillars of the nose, how I am imagining the pillars of the nose, and why I call this theme the pillars of the nose. Because I think that all wisdom starts with a solid foundation of knowledge, of maturity, experience, happiness, and health. And foundations are a very important part of our successful life. Every house must have a foundation. If you take a few moments to stop and to observe the foundation of a new home being built, you will see that trenches and dikes, then filled with concrete or cinder blocks to support the house. From the ground up, buildings have an endless variety of shapes, sizes, designs, but the strong pillars are required to frame and support the building as it is built at its eventual height. In our life, integrity, truthfulness, and purity are far greater in value than being cool or being hot or popular or bad. If your character is built on strong pillars, as you can see here, I was impressed about the pillars of the cathedrals and churches. Your character is built with strong and true. It will support you in all you do in your life. It will bring you respect, trust, and honor. So it's the same with the pillars of the nose. You can build and change the foundation and size. You can play with different forms. You can model the facade. But what is the facade without the interior, without the pillars of the nose? You can gain everything, but you can also lose everything. That is the essence of my lecture today. Take care of the pillars. Anyway, who needs only aesthetic without function? The overprojected nose presents a significant challenge to the surgeon performing rhinoplasty. So the rhinoplasty surgeon must understand the concept of nasal projection and with preoperative analysis to determine the ideal position for the nasal tip after having understood and defined the ideal position for the nasion. For the nasal tip, I can also say that nose is the central feature of the face, has a profound effect on a facial aesthetic. We know, all of us know that classic facial aesthetic is based on Greek-Roman ideal, but nowadays it's much more important to look like natural. The modern trend is a strong nasal profile and a much more natural, unoperated look. For nasal tip projection has been defined as a distance along a perpendicular line from the vertical facial plane to the most anterior projecting point of the nasal tip. And the three-point concept is almost everywhere accepted. The three-point concept, although is one oversimplification of the nasal tip dynamics, highlights the intimate relationship between projection and rotation of the nasal tip and nose. As you can see on this photo, which are a computer-made photo, on photo 1, photo A and photo B, only the nasal projection make difference. The projection is the same in the same part, A and B, but there are some changes in the radix. In radix positioning causes the illusion of overprojected nose in part B. Before you plan operation for overprojected nose, you have to make facial analysis first. then nasal profile, the interrelation of the tip with rotation, projection, and nasal end. Then take care for the skin, of course. Make palpation to the nose, because palpation will help you to determine the tip support, to identify septal character, and help visualize cartilages. And now we are going back to the pillars of the nose. They are very much important for the surgical anatomy. The medial crus, the dome, the lateral crus, the tip defining point. The term crural arch refers to the alar cartilage in its entirety. The components of the crural arch are the lateral crura and the medial crura. They are joined by a transitional segment of cartilage in the dormal region, which is termed in intermediate crura. The caudal portion of the quadrangular cartilage also contributes significantly to the anatomy of the nasal tip. The caudal septum has three distinct angulations: the anterior septal angle, the mid-septal angle, and the posterior septal angle. The posterior septal angle is located just above the articulation of the quadrangular cartilage and the nasal spine. Very much important for the surgical anatomy is always to take care for the lower lateral cartilage and how to operate the lower lateral cartilage, then for to take care for muscular attachments and for the nasal tip. Yes, there are several surgical approaches. I will, because of the time, I will not going to explain, because you can find it in every book. It's transfixion and hemitransfixion incision, partial transfixion incision, high transfixion incision. There are different approaches, then non-delivery approach, open approach, and delivery approach. These are some methods, but I will go into the points. Our points is that we completed a retrospective review of patients who have been admitted at ENT University Clinic in our campus, St. Mother Teresa Skopje, in the period of 211-219. We prepared operative techniques, septorhinoplasty, were prepared in 72 patients, and procedures included full transfixion incision, release of tension septum, lateral crural overlay, dome trunction, medial crural overlay, and combination, of course, of all of them. Patients underwent preoperative and postoperative evaluation during the period on a regular basis to record the effects of various approaches of the nasal projection, rotation, need for revision, and patient satisfaction. So on this graphic, you will see the operative technique and patient location. In most of the patients, 32, we made lower lateral cartilage overlay and medial. Then in 14, only medial. In 20, lateral, and in 12, only dome trunction. Non-trunction. And the result, 62 patients were very much satisfied, that means 89%. Then 3% were not satisfied and went for revision surgery. Then 1% underwent radix graft. Then 1% required minor revision of dorsal irregularity, and only 4% required tip revision again. And now I will show some cases. This is the first case. Usually we are performing closed rhinoplasty technique. It's a girl with rhinokyphosis, overprojection nasal tip, long nose. I do reducing of the nasal hump, rasp dorsum, medial and lateral osteotomy, septal medial position, resection of lateral alar cartilage for alar rim grafts, dorsal graft with crushed cartilage and caudal end at tip reconstruction. The other case, overprojected nose again with rhinokyphosis, again rasping the dorsum, lateral medial osteotomy, and a tip refinement or tip rotation before and after the surgery. The other case, you can see a typical Pinocchio nose, long nose, overprojected nose. Again, the same tip refinement, lateral osteotomy, medial osteotomy, shortening the nasal septum, medial crural resection, and these are the results before and after the operation. Another case, a young girl, it's not so young, 60 years old, with a subluxation of the septum, you can see on the second photo. Then overprojected nose, hump, and the results after the surgery. Another case, another girl with rhinokyphosis close to the radix of the nose, the same procedure again, and before and after the surgery. Another case, again, case number 7 again. Case number 8, a long tension nose, nasal septum deviation, overprojected nasal tip, nose under the tension of the long septum, septal medial position again, lateral medial osteotomy, cranial rotation and refinement of the nasal tip, medial crus reduction, nasal hump reduction. Case number 9, a wide nasal dorsum, very bad nasal tip, and the result before and after the surgery. Again, a long nose and the tip under the tension of the long nose. Again, medial and lateral osteotomy, hump reduction, septal medial position, and result before and after the septal surgery. I have to say that we are happy in Macedonia that we have a lot of rhinoplasty. I think that Professor Netkovski will be agree, maybe because of the population and especially for population because of the population, sorry. In conclusion, the surgeon have to reduce excessive tip support mechanism, reduce overdeveloped anatomic components, and normalize adjacent anatomic components. And as with any rhinoplasty, tip asymmetries can arise. However, our revision rate of 4.2% for tip irregularity and our finding that no patient had postoperative functional complaints allow us to feel confident that this algorithmic paradigm can be used to accomplish tip deprojection in almost any circumstances. Thank you very much.